So thank you. This is the experience from the IMS with retroauricular gasless robotic thyroidectomy. Certainly, it is being supplanted by other ways of remote access thyroidectomy, including transoral and BABA techniques. We still continue to prefer this in most situations, not in all. We are experimenting with the other ones too. And I'll tell you why we do this. So many ways of doing remote access thyroidectomy. This continues to be quite viable in our practice. Why? Because obviously the robot gives you a good 3D magnified vision and more importantly, a stable tremor-free field. That's what you want. It's a familiar approach. This is very important to us. It's within the repertoire of our skills. If you're a general surgeon and you are used to laparoscopy and CO2, then that's okay. But for us, this is something new. And most importantly, you can get going with fairly large nodules on this technique, while the other techniques pose challenges with larger nodules. The problem, of course, is that it is largely a unilateral operation for a hemithyroidectomy. That is the problem. If you want to do transoral, you can combine it with axillary, and Dr. Tay talked about it this morning. We have worked with him, and yes, it is something that can be done. We have had some initial experience with it, but the concern with both transoral and BABA is primarily that you have to do CO2 insufflation, and then there is this small concern that if you get a vein, then you are risking air embolism or CO2 embolism. And that is something that we may not be fully comfortable with. The advantage you get with the other techniques is that you get bilateral access, so you can do a total thyroidectomy. But transoral is very difficult to get involved with larger nodules. BABA you can, but again, it's not so easy to get that specimen out because you have to bag it and then get it out. So when do we do this? We do this primarily when we want to do a hemithyroidectomy without node dissection. That's when we want to do it. The advantage is mainly cosmetic, and because that is the advantage, we basically focus on being very safe. So currently our indications have moved on from a 3 centimeter nodule to a 5 centimeter nodule, but with cancer we still stay with 3 centimeters. With benign lesions we go on to 5 centimeters, and no central compartment dissection, as I said. So the prime thing is that it can be done, but if you only do it when you feel it's safe to do. So in other words, if I see a patient wherein I have planned a hemithyroidectomy and a patient wherein I am happy to do this by capsular dissection, there is no extrathyroidal extension, then we offer robotic thyroidectomy. So the equipment, of course, you know the equipment. You need a self-retaining retractor, and you need the Da Vinci robot with the equipment that you have seen a fair bit in this meeting already. We use nerve monitoring routinely. We use ICG routinely. 2 steps. One, you raise the flap, get the robot in. Next step, you get the robot in and do the excision. But there is also a step 0, which I think is very important, like all robotic situations, because you can't palpate the lesion while you're doing it. So you have to be very good at radiology and know exactly what you're going to be doing. So I would myself do my ultrasound the day before, just to get the lie of the land. Can I hold this tumor on the superior pole? Is it getting to the isthmus? Is it crossing the isthmus? So that I know exactly where to go when I'm doing the operation. And then, of course, the same 2 steps. So let me take you through them. First is a retroauricular incision, which doesn't go too high in the retroauricular situation. If you take it too high, then you risk flap ischemia and flap darkening and flap necrosis. And posterior limb goes down in the hairline till as far down as the hairline, and a centimeter or so behind the hairline. So this can take you fairly low. The posterior lip can go fairly low, and then you move forward to raise the flap, find the greater auricular nerve, preserve it. You can see it. Find the external jugular, preserve it. You can see it there, and then move along the sternomastoid. Moving along the sternomastoid, get a retractor and Go down right till the sternal notch. Get a fairly wide pocket. Open the space between the sternomastoid and the straps and find the thyroid. So all of this is done without docking in the robot. And before you dock in the robot, you do this. If you see the omohyoid, you will see the omohyoid. And for larger tumors, you would almost invariably have to cut the omohyoid. Lastly, a suture on the sternomastoid to retract it laterally. And then the whole thyroid nodule can come into view as you see it here. Once you're ready, you dock in the retractor. And this is what it looks like once you're docking in the retractor. So the retractor's in, and then you get your instruments in a 30-degree scope, because then you can angle it a little bit from downwards and leave space for the other instruments to come in. And the scissors, which is a monopolar, the bipolar Maryland, and the ProGrasp. So because you've done an initial ultrasound, you know how to go about where to clutch, where not to clutch. So get the upper pole, dissect the upper pole, the same steps that you do routinely. So the vein, the artery, and the nerve, as you can see in the superior pole. So the vein's taken, the artery, and you can see the nerve there. You can use nerve monitoring, of course. And that can confirm the superior laryngeal nerve if it needs confirming, but it's nice to have. You can see the parathyroids here quite clearly, but we again use ICG quite routinely to reconfirm if required. So you can see ICG, the parathyroid lights up. ICG will light up anything that is vascular. In this case, the tubercle of Zucker-Kendall was also lighting up, and another parathyroid there. So you confirm the parathyroid, and then once you have got the parathyroid and you have got the superior pole, the next step, of course, is to find the recurrent laryngeal, which again you will find just in relation to the tubercle of Zucker-Kendall. You can see it under the fascia. You could use nerve monitoring to confirm. And once you've got the nerve and the parathyroid, then really it's really a question of lifting the thyroid up and cutting the isthmus. The best part about the operation is that the specimen comes out easily. You don't have to bag it. You don't have to struggle to get out a big nodule or a big hemithyroid through a port. And so this is easy. It just comes out easily. That, to my mind, is the biggest advantage with the kind of pathology we see, where largely tumors are larger. And then you go back and check the vascularity of the parathyroid and check the integrity of the nerve if it needs checking. And close the incision. So that's straightforward there. Quite satisfied with the cosmetic results. I know there is talk about hypertrophic scars and keloids. We haven't had a problem. I haven't said that we have never had a problem. It's not really been a problem. Part of the reason probably is because we don't take the incision as high as others do. We keep it a bit low, and to keep an obtuse angle. Our results till last year. So nodule sizes have gone up over the years. We have had one conversion to open in the initial experience. We've had one hypertrophic scar. We've had one tracheal injury, which wasn't too much of a problem, mild subcutaneous emphysema in the post-op period, but that was early years. But we have had far more cord paresis than we normally have with open. These have all been transient, so that's a different matter. But I think because you can't quite, especially with large thyroids, you can't quite retract as well and open the space between the trachea and the thyroid as well, and you can't do sharp dissection with a knife. So this is something you have to be a little bit careful with. So that is it. Thank you. So as I said, these are the advantages, and it's a safe way to move forward. To my mind, it's a safe way to do a robotic thyroidectomy. Thank you. Yeah. Thank you.
I would request all the speakers and the chairpersons to come on the dais for a photograph. I would also request Dr. Sareen sir to be present for the photograph. Thank you so much. We'll resume the session in this hall at 4:15 and we go for a tea break now. Thank you.